Hey guys, it's Jen. I hope you're all doing well. Welcome back to the iFitNurse Pearls series. This is video number 8 discussing NG tubes. Okay, nasogastric tube or orogastric tube. So it is a tube, a catheter that we do insert to be used for many different reasons. So first thing is first, make sure you assess your patient. Do they need one? And if so, make sure you get an order for it, okay? So this NG tube, so when I get students, this is probably one of the best skills to help them learn. And it can be very scary, okay? And it's a very uncomfortable skill to do and perform, especially in front of the patient, obviously, if they are alert or oriented, or even in front of family. For the most part, whenever I do a skill with a student, I do ask them to step out, and this just provides us the opportunity for the student to be a little more comfortable. It's still very scary, nerve-wracking. You probably start sweating. With any other skill, identify yourself, identify the patient, explain to them what has been ordered, what you're going to do. Sometimes understanding that process helps them to prepare for what's to come. And I will always be upfront and explain this is really uncomfortable. I will do my very best to do this procedure with, the least amount of discomfort, but it is uncomfortable. I can't take that away. We just have to communicate. You have to let me know, can we, do I have to stop, or do you need a break or anything like that, okay? So supplies you want to have available. You may need a second pair of hands, okay, especially if the patient will start fighting you, trying to obviously get your hands out of the way, and you need to insert the tube, okay? So obviously clean gloves, doing your hand hygiene, making sure you choose the correct size. So next time you're in your supply room, go and take a look at the different available NG tubes, okay? So again, with every patient, depending on the size of the patient, what it's for, there's a gauge side. So how big is the actual catheter? And then it also has a length dimension on there as well. So you, for the most part, I pull for 14 or 16 French catheters. For the most part, it's 16, but again, it depends on the patient, okay? If I have someone who's really small, fragile, I will probably go for 14, or, and so that's a big thing. And that goes with anything else, any foreign tube. Look at the patient, assess, and what size is appropriate for them. Okay, so a couple things that I've learned. So an NG tube is really stiff. So what I've seen, sometimes it's really hard. So when you're inserting the NG tube, it can be really stiff and it doesn't bend, and you keep hitting the back of the throat, right? And so what I've ended up doing is sometimes I'll just run it under warm water just to make it more pliable. And that seems to be a little more comfortable to the patient. And then sometimes I'll kind of loop the end so it has a nice little curve. So when it goes in, it'll curve nicely down instead of and you're trying to just force it down. Okay? Obviously have all of your supplies readily available and your lubricant. Yes, your lube. What I end up doing is literally either putting it a little bit on there and on the actual catheter, or inserting the catheter in the little lube packet until I am ready. Make sure you have some ice water, especially for the patients that are alert and are able to swallow. That will help them swallow, and as you swallow, you advance, right? So you can get into the esophagus and then get entry into their stomach. So yeah, so that's a little tip. Going backwards in a sense of indication. So with this NG tube, why are we using it? Okay, so is it to decompress your stomach? Is it to give them medications? Maybe they overdose on something. Do they have an obstruction? Do we need to relieve the pressure? Do we need to set it up to intermittent suction? Do we need to do continuous suctioning? Do you need to administer medications? Do you need to feed them, give them nutrition? Do you need to assess for any GI bleeding? So this tube allows us to gain entry to their GI system, okay? And what I tell patients and family members, especially if, let's say, a patient was recently extubated, they're not passing their swallow steadies, it's unsafe at this moment to give any medications, any liquids through the mouth, or have them eat anything. So at that point, we still want them to be able to have the nutrients and the calories that they require for their body, right? So in that case, if we're not at the point where we need to get like a central line and do TPN type of nutrition, we can hook them up to nutrition and like administer it through the NG tube. So like it could just be for a couple of days until their muscles kind of regain, they become more alert, then we can always reevaluate and take the tube out. It is uncomfortable, but it would allow us access to not only administer medications that they may need, but to allow us to give them the nutrition in the meantime as we move forward, okay? And going back to when you're actually going to do the insertion. So I mentioned the water is a really good tip. I mentioned having a second pair of hands is also a really good tip. Any skill, you're gonna feel the pressure, take your time. You do not want to rush this because one, it's already uncomfortable. Two, if you're being too forceful, they're gonna not let you finish. They're gonna be like, stop it, don't do it anymore. And if you find yourself in a position where like they need this medication, there's no other way to give it, I need for them to get it, then you can find yourself in that position. So you don't want that. Obviously, get your gloves, clean everything, open everything, make sure it's lubricated, make sure you have ice water, that the straw is there, and then take your time, okay? So obstruct one of the nostrils. If they're lower oriented, they can breathe in and out for you, all right? Take a look at your flashlight, look up there, make sure there's no like deviation or anything in there that could cause any obstruction, okay? And then whichever side you decide to go on, obviously stand on that side. So if you're going to insert it on the right near, stand by the patient's right side, okay? I normally have my patients sitting up, really upright, and then I let them know that I'm going to get to the point where I want you to tuck your chin, right? And I want you to swallow and drink this water, okay? So it's gonna feel uncomfortable, you're gonna feel pressure. If you start coughing, what I will do is I will pull back, let you relax, and then I'll keep trying to advance the NG tube, okay? When you go back there, so I normally count, I like to count like, okay, here we go. I'm gonna insert it, okay, I'm inserting, and I'm literally going in. And then I want you to put your chin down, okay? Here's some water. So chin down is very important. So you want to get into like their esophagus. You don't want to get into like their trachea to go into their lungs. That's what you're trying to prevent, okay? You're trying to get into past their pharynx, down to their esophagus, into their stomach, and depending on where, you may need to advance it more, okay? So we'll talk a little later about confirming placement, but that's what you want to do. So having the patient upright, and sometimes you'll need that other nurse to kind of hold their neck and help them position it, because your instinct is to pull away, and that's not going to help you get that tube down, okay? And take it slow. Take it slow. If they start coughing, you may see some tears. Just freeze right there, pull it back. So if you're irritating the epiglottis, you're up. You're not touching it anymore, and they can kind of calm down and all of that. Just be aware that it can induce vomiting. So make sure you have suction available. It's really uncomfortable. So once you get to the point and you're advancing, and then they're sipping. So as they sip, swallow, you advance, right? And you will feel almost like a sucking motion too, as their system moves down, and you can feel in advance, and it nicely goes into their stomach. So what you don't want to do is just jam it in there like, is it in there? That's so uncomfortable. So work with them, explain to them they will cough, give them a break, and then start drinking water. And normally that really does help. Okay, so let's say it's in there already. So depending on your hospital and what the protocol is and policy, normally you aspirate for the stomach content and you test it. Check the pH, normally it's less than 6. And sometimes you go ahead and do an auscultation test. So you would get your piston syringe, maybe with like 30 cc's worth of air, put it at the end of the NG tube, listen, put it over their stomach, okay? And then you would hear the whoosh of air into your stomach. So going backwards, I should have mentioned properly measuring and marking so you know how far you will advance the tube. So let's rewind that and let's talk about that, okay? So again, every patient's different. So you want to measure from the tip of the nose to their, like the back of the ear up here. And then you want to measure from here all the way. So you have like your sternum and your stomach. So like right in the middle. So I would always, like with my hand, I would assess my patient. Okay, now I'm feeling the stomach right below the sternum. I'm gonna go halfway and then I'll mark it. Make sure you mark it. You don't want just to eyeball it and next thing you know, you're so flustered on trying to get it in and then you forgot which dot you measured. So grab yourself a Sharpie, mark it, and then you look, I'm like, okay. And then I do it again. So after I mark it, I go ahead and measure. And then I'm like, okay, now I know. All right, so fast forward to you got it in there, you are listening, and you got either gastric contents and you tested it. So you want to secure it. There's nothing worse than working so hard getting this NG tube and then it slips out or the patient pulls it out. So have your NG tube holder. Sometimes you may need some skin prep to prep the skin to help adhere the adhesive from behind that like bandage so it can stick. Some people have really oily skin and it just does not. So I find it cleaning it really well with that skin prep does help. And then for the most part, sometimes you may do like your tape and split it in half and then wrapping it around. I hate that technique because it leaves so much like residue. So I normally use a holder right away before it's even confirmed by x-ray. Be a prudent nurse. You know this is part of your skill and your training. Follow up with an x-ray, okay? And do not use it until the radiologist looks and puts the report in saying NG tube incorrect placement, you know, blah, 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 or a physician puts in and may use NG tube, okay? You do not want to say a medication you've been wanting to give, okay, got the NG tube in, yeah, I hear it, and you just skip on following up with the x-ray. So just follow your policy and your protocol. I will forever get an x-ray after I insert an NG tube, okay? There have been many instances where they think it's in the stomach, it's in the lung, and they start nutrition or feeding or anything like that, or they cause a pneumo. That's another reason why you want to get an x-ray. Just because you feel like you listen and it's in there, what if when you first tried you caused a pneumo and then you got it in? You know what I'm saying? So that x-ray will give you the best impression of where that catheter is, and it will give you the full confidence that you can use it, okay? There are instances where some nurses that have been nursing for like 20 something years, oh, I know it's in. I am sorry, I'm not gonna put my license on the line. I'm gonna go ahead and follow up with an x-ray, okay? Again, patient safety. You do not want to, if you ever question, so for instance, I had a situation where I had a patient with the NG tube. We were returning. You'll see this, especially this is if you don't use the NG tube holder, even when you use the NG tube holder, but like the tape, sometimes it just starts slipping out. You're like, go back in there. So if it gets to the point where it's too much, or maybe you can save it and you reposition it in there, it could be in a whole different area. So what I end up doing is, okay, I need to get an order so I can get another x-ray to reevaluate the position of the NG tube. So it never hurts to double check. Again, this is the patient's life, okay? You do not want to end up in the lungs. You don't want to cause a pneumothorax. You don't want the catheter to be advanced in too far if it's not needed there, okay? And then with any other type of like invasive tubes that we do, take care of it, okay? Make sure that it's secure properly, that it looks good, that it's patent, that you're flushing it, that it's not obstructed, okay? This is the way that we're providing the nutrition and food and medications to this patient. What else? I think that's pretty much it on the NG tubes. Very similar to Dopphoff's, but that's a whole different like insertion type of thing. So I'm not going to go into that. So if you have any questions, leave it in the comment section below. Don't forget to comment, like, and subscribe and share the videos. Bye.